3, 2, 1. Good evening again, my dear friends and audience, CEC members from all over the world. Tonight we are discussing Wave 3 from the European Society of Cardiology 2020 guidelines at CEC. We will be discussing adult congenital heart disease, grown-up congenital heart disease, ACHD GUCH guidelines. We have a very eminent board tonight. We have Professor Amira Noor, lecturer of cardiology at Ain Shams University and consultant of congenital and structural heart disease as a speaker. And we have two eminent moderators, Professor Soha Rumeh, consultant adult congenital heart disease at Aswan Heart Center and director of the Advanced Cardiac Imaging Program, as well as Professor Haitham Suleimani, consultant of cardiology at Al Fayoum University and lecturer of cardiology there. So Dr. Amira will give us a snapshot about the updates in different adult congenital heart disease, and this will be moderated by Professor Soha and Professor Haitham. So if you are ready, Amira, you may start sharing your slides, please.
Yes, I shared my screen now. Is it okay or not yet shared?
Not yet, Amir.
Not yet.
Okay, Dr. Salah, okay.
Now it's okay.
Now it's clear.
Okay, I shared.
Yeah, it's okay.
Okay.
Amir. It's clear.
Okay. First of all, I will take you through a smooth journey in the latest adult congenital heart disease guidelines. And actually, the latest update of the guidelines was in 2010, and it was under the name of grown-up congenital heart disease. First of all, there was a very interesting illustration in the beginning of the guidelines. It illustrates that congenital heart disease is a lifelong chronic condition starting from the neonatal period up to the adulthood stage, and during this lifelong period it is full of repeated surgical operand catheter interventions, recurrent hospitalization, and episodes of recurrence of the congenital heart disease with decreased exercise tolerance and sometimes social and psychological impact on those individuals due to reduced quality of life, and multiple pregnancies complications with increased both maternal and neonatal mortality. And it is also associated with lifelong medical therapy and long-term complications as arrhythmias, coronary complications, cerebrovascular complications, and definitely reduced life capacity. So I will give a scheme for adult congenital heart disease. First of all, this scheme could be applied for any adult patient with congenital heart disease. First of all, the clinical presentation and natural history, and we have three main categories for those patients: patient with shunt lesions or left to right shunt lesions, patients with obstructive lesions, and patients with complex cyanotic heart disease. The patients with left to right shunt, they start from being asymptomatic up to later on exertional dyspnea and effort intolerance up to complete reversal of the shunt with and transformation into Eisenmenger syndrome. And obstructive lesions, either LVOT tract obstruction or RVOT tract obstruction, where the symptoms also vary according to the degree of obstruction. For example, we may have adult patients with mild pulmonary stenosis and they are asymptomatic. We may have patients with severe pulmonary stenosis or severe LVOT tract obstruction, and they should undergo intervention. The last category is patient with complex cyanotic heart disease, and actually those the group are with the lowest prognosis, and either we follow this patient as unoperated, or those who were misdiagnosed or left untreated to the adult age, and actually they are of very low percentage. However, the majority of those patients are those patients where we see them after surgical intervention, either palliative or total surgical or corrective surgical repair. The second is that in those group of patients, we face many complications after surgical repair. And generally, these complications are systemic ventricular dysfunction, systemic AV valve regurgitation or dysfunction, arrhythmias, and they vary from supraventricular, all supraventricular tachycardias, atrial tachycardias, AVNRT, AVRT, atrial fibrillation, and up to ventricular tachycardias. And also, after surgery, it may be complicated by LVOT or RVOT obstruction and residual lesions, as we may see patients with residual VSD after tetralogy of Fallot repair. So the diagnostic workup for any patient with adult congenital heart disease, first of all, you should go stepwise, as in this slide. You should do the ECG, and sometimes you need to do a 24 hours Holter monitoring, as you need the ECG to diagnose or document an arrhythmia. As I said, all forms of supraventricular tachycardias and ventricular tachycardias, and chest X-ray is also important for assessment of cardiac enlargement and congestion, whether there is congestion or lung leukemia. And echo, of course, is the first line method for diagnosis or for proper diagnosis of those patients. And of course, sequential segmental analysis should be should be our steps to diagnose those patients. And of course, the echo is the most common non-invasive method for assessment of pressure gradients and non-invasive assessment of pulmonary artery pressure. Then we move to a more advanced imaging modalities is the multi-slice CT and the cardiac MRI. And I will discuss in the next slide which is of them is superior to the other in certain indications in congenital heart disease. And of course, the forgotten test is the cardiopulmonary exercise test, which is very important in those patients for assessment of their functional capacity and measure if they are desaturated during exercise or not. And actually, through this test, we can determine the degree of exercise or exercise limitation for those patients. Finally, the cardiac catheterization, and of course, it may be of a diagnostic purpose or hemodynamic purpose for invasive assessment of different pressures and saturations from different cardiac chambers, invasive assessment of the pulmonary vascular resistance and the pulmonary artery pressure. And of course, cardiac catheterization is a prerequisite before Fontan completion. For fulfillment of the criteria for choosing the proper candidates for Fontan. Regarding the cardiac MRI or the preference of cardiac MRI versus multi-slice CT in patients with adult congenital heart disease, actually the cardiac MRI is superior, as we all know, in quantification of right ventricular volumes and functions, especially if this right ventricle was the systemic ventricle or it was a single ventricle, and in patients after tetralogy of Fallot repair. And of course, it is the gold standard in quantification of the grade and severity of pulmonary regurgitation in patients post-Fallot repair, and sometimes evaluation of the right ventricular outflow tract obstruction and RV to pulmonary artery conduit. And also cardiac MRI has a main role in detection and the quantification of myocardial fibrosis and scar in patients after surgical repair, and of course in assessment of the shunt fraction also in those patients. However, the CT, as we all know, it is more superior in assessment of the great vessels, I mean the pulmonary artery and the aorta. If you have a pulmonary stenosis, or if you have a pulmonary aneurysm, an aortic coarctation, and aortic aneurysms, and it is also superior in any extra cardiac in all extracardiac structures and assessment of coronary anomalies and any arteriovenous malformation or pulmonary arteriovenous fistulas or collaterals. So this table, I think, is very important to know which is superior. CMR is superior in certain situations. However, multi-slice CT is superior in other. So it is very important to know which imaging modality you will ask the patient to do in the next step. Regarding the management, first of all, we have medical treatment and then surgical or catheter intervention. And medical treatment, it may include an anti-failure treatment for those patients with systemic ventricular functions or treatment of pulmonary hypertension as the phosphodiesterase enzyme inhibitor or endothelin receptor antagonist, which are proven to be of benefit in patients with adult congenital pulmonary hypertension, and whether they will we will favor a surgical or catheter intervention for those patients. And we don't forget that you should advise your patient regarding those 3 points, regarding exercise restriction, whether he will limit exercise or not, or to what extent those patients can exercise, and regarding pregnancy and contraception, and we discussed it in details the last session, in the previous session. And of course, prophylaxis against infective endocarditis is very important in all patients with adult congenital cyanotic heart disease, and patients with shunt lesions or with high velocity shunt lesions or residual shunt lesions after surgery, or patient who did either surgical or transcatheter surgery and
Hello, everyone. I think we have
Yes, I think we have a problem with the connection. I lost
Amira
the
was
connection.
disconnected.
yeah.
Yeah.
Can you, Soha and Haitham, please, just until Amira is connected again, can you give us a gentle wrap up of what Amira said until now, because the audience are live with us on the YouTube?
Yeah, sure. So
Go ahead,
first of all, yeah, please go, Haitham.
Go ahead. No, go
So
ahead.
first of all, Amira gave a nice general overview about the congenital heart disease in adults. So I did like the classification, the general classification, the first of the shunts that include the ASD, PSD, and BDA. Then the obstructive lesion, whatever for LV and RV with the categories. Then the last one was the cyanotic complex congenital heart disease. And then she went to the complication and post-operative, either it's arrhythmia or systemic ventricular failure, either it's a left ventricle or right ventricle. And I thought this is a nice start to think about the approach of the congenital heart disease. What do you think, Haitham?
I think what Amira did marvelously is to show us the first slide, which highlights the continuous relationship between the doctor and the patient, or the journey of the congenital heart disease patient. It's not an absolute curable disease. It's a long relationship and long follow-up between first the pediatric cardiology, then the adult cardiology, and the patient, including too many aspects: the quality of life, the pregnancy, the exercise, the follow-up, the expected complications, and the limitation of the life. It's a long journey with long education or mutual relationship between the patient and the doctor, with a lot of information to be learned from these patients and to be delivered to these patients about their life, about the management and the expected complications.
Indeed, yes, I do agree about that. Yes, indeed, this life commitment, as we said.
Yeah, and also Amira has highlighted that we do in our practice use some essential tools, and we forget about some of these tools, like the cardiopulmonary function tests, which is extremely important in evaluating these patients. So we have to be knowledgeable and to select the type of investigation of choice in every patient and what we are looking for.
Yes, indeed. Yeah. Amira is back, I think.
Yes, yes, Dr.
Soha. Share your screen.
Yes, I think I was in this slide. I was talking about this or discussing the management for patients with adult congenital heart disease regarding medical treatment. It may be an anti-failure treatment, for example,
please,
or
please share the screen, Amira.
Yes, Dr. Soha.
Please share the screen. We are not able to see the screen.
Okay. Yes, I'm sharing now.
Yes.
And also those patients may need either surgical or catheter intervention. And I was pointing to that there are 3 points patients with other congenital heart disease should be advised regarding them, which are exercise restriction and pregnancy and contraception, where we discussed in details as a previous session, and prophylaxis against infective endocarditis. And prophylaxis against infective endocarditis is essential for all patients with adult congenital cyanotic heart disease and patients with residual shunt lesions after surgery or after closure for 6 months after closure of shunt lesions, either surgical or transcatheter. And I was pointing that we have 3 main comorbidities in patients with adult congenital heart disease, which are heart failure, arrhythmias, and pulmonary hypertension. Regarding heart failure, we may have both systemic ventricular failure or either biventricular failure. And as I said before, anti-failure treatment, including diuretics and ACE inhibitors, may be of role in those patients. And of course, in patients with in late stages or end stages, ventricular assisted devices may have a role. However, sometimes in patients with poor prognosis, we may need to do heart transplantation or heart-lung transplantation. However, sadly enough, those patients came on the bottom list for heart transplantation or heart-lung transplantation because they have multi-system disorders or dysfunction, which make other patients, for example, with dilated cardiomyopathy or hypertrophic cardiomyopathy, on the top of list for transplantation. Regarding arrhythmias and sudden cardiac deaths, actually the guidelines have emerged with 2 important points that was not previously mentioned or discussed, which are the catheter ablation. Now, catheter ablation is recommended as a class 1 in patient with mild congenital heart disease and class 2A in patient with moderate and severe congenital heart disease, who are symptomatic with sustained supraventricular tachycardias, either AVNRT, AVRT, or atrial tachycardia, not responding to medical treatment. And I think these 2 points came nowadays due to the new techniques or emerging devices in electrophysiological ablation and 3D mapping, which enabled us now to ablate such pathways in patients with structurally diseased heart and abnormal anatomy and morphology. And also in regarding ventricular tachycardia, of course, ICD implantation is indicated in patients with adult congenital heart disease, the same indication which applies for the general population. It also applies in patients with adult congenital heart disease, which is patient who face the cardiac arrest or hemodynamically significant ventricular tachycardia. It is class 1. Even in patients with adult congenital heart disease who are symptomatic with NIHA class 2 to 3, ejection fraction less than 35% despite more than 3 months of optimal medical treatment, ACHD is a class 2A indication in those group of patients. And regarding the third comorbidity, which is the pulmonary hypertension, the guidelines had changed dramatically in this point, especially as they lowered the threshold for definition of mean pulmonary artery of pulmonary hypertension, where it now becomes to 20 millimeter mercury. So pulmonary hypertension is defined as if the mean pulmonary artery pressure is more than 20 millimeter mercury. We consider those patients with pulmonary hypertension, and we shouldn't forget that patients with adult congenital heart disease, they may have a pre-capillary pulmonary hypertension or an isolated post-capillary pulmonary hypertension, which is where the main difference between them is the pulmonary capillary wedge pressure. If it is less than 15, it goes with a pre-capillary pulmonary hypertension. More than 15, it goes with isolated post-capillary pulmonary hypertension. Another important point that they also lowered the threshold for pulmonary vascular resistance to be more than 3 Woods unit. However, previously we considered it even more than 5 Woods unit. And again, I want to stress on patients with isolated post-capillary pulmonary hypertension. They may have pulmonary hypertension due to systemic ventricular dysfunction, systemic severe AV valve regurgitation, pulmonary vein obstruction, or core tritratum. And regarding the pulmonary hypertension in patients with adult congenital heart disease, I just want to note that we have 4 important clinical subtypes, which actually were illustrated in details in the guidelines for pulmonary hypertension, where you may have a patient with Eisenmenger syndrome, where they used to have a large intracardiac or extracardiac shunt, and which was shunting from a systemic to pulmonary artery. And with the reversal of those shunt, these patients developed Eisenmenger syndrome due to elevation in the severe elevation in the pulmonary vascular resistance and development of severe pulmonary hypertension. And the second group is those patients with moderate to large defect. However, they still, despite the development of pulmonary hypertension, the pulmonary vascular resistance is mildly or moderately elevated, and there is even still a small systemic to pulmonary artery shunting. So cyanosis is not a feature of this group. And the third group is the patients with coincidental pulmonary arterial hypertension. And in this group, they have small defects. For example, they have a ventricular septal defect less than 10 millimeters, or an ASD, which is less than 20 millimeter, and they have a significant pulmonary hypertension, which is not explained by these small defects. And actually, closure of these defects is contraindicated in this group of patients, as they act as a vent for the right side, and if we close them, this patient may develop a pulmonary hypertensive crisis, or acute right ventricular failure, or severe RV diastolic dysfunction. The third group is that those patients, after correction or after surgical repair, they still have pulmonary hypertension, or pulmonary hypertension may appear after surgical repair. So these are the 4 main clinical subtypes of pulmonary arterial hypertension in patients with congenital heart disease. But we shouldn't forget patients with Fontan circulation, as later on they started to develop pulmonary hypertension and pulmonary vascular disease, and it was explained in details in the section of Glenn and Fontan circulation. And we shouldn't forget also those patients with segmental pulmonary hypertension. And actually, this category of patients are also forgotten, as for example, you may have a patient with pulmonary atresia and ventricular septal defect, and you may have a PDA or a collateral supplying one of the lungs, and the other is not supplied. So you will have an overflooded lung, and the other lung is oligemic. So this is called segmental pulmonary hypertension, and actually this is the most difficult group in management. Regarding the management of patients with congenital heart disease and pulmonary hypertension, the guidelines stated that pregnancy, they should be counseled against the pregnancy, and this is class 1. And the risk assessment for those patients is of utmost importance, and we can start in patients with low or intermediate risk with a single drug therapy or even to a sequential combination therapy if not responding. Regarding those patients with not only adult congenital heart disease, but patients with adult congenital cyanotic heart disease, they are a fragile group of patients, and they have more complications than the other two categories, for example, obstructive lesions or only simple shunt lesions. Those patients develop later on hyperviscosity syndrome due to hypoxia and reactive erythrocytosis, and consequently they develop thrombotic complications and at the same time bleeding diastasis, as was the increase in marked increase in the number of RBCs, despite they are increased, but they are dysfunctioning. So these patients also have bleeding complications, and consequently they will develop iron deficiency anemia. Also, those patients commonly have paradoxical embolization and cerebrovascular disease, either in the form of cerebrovascular stroke or brain abscess or mycotic aneurysms, and so on. Infectious complications as chest infection or infective endocarditis, renal dysfunction, and cholelithiasis. And we should be taking measures to avoid these complications, or some strategies to reduce the risk. For example, patients, as we discussed in the previous exercise, should be advised in the previous session should be advised against the pregnancy, and iron deficiency anemia should be treated properly, and we should avoid in this patient unneeded phlebotomies or venesection. And also this patient should avoid dehydration, and they should be vaccinated with influenza vaccine to avoid recurrent chest infection, and also they should quit cigarette smoking. So the first part of my lecture, we came now to its end, and now I will start to discuss specific lesions, mainly what are the indications for intervention regarding those specific lesions in patients with adult congenital heart disease, and whether the intervention will be either transcatheter or surgical. First of all, I will discuss patients with ASD, and actually the guidelines in 2020 have dramatic change in this in regarding patients with in intervention in patients with ASD, either it was native or residual. As we all know, ASD closure is indicated in patients with significant right ventricular volumes, provided that the pulmonary vascular resistance is less than 3 and they don't have significant LV dysfunction or increase in the left ventricular end diastolic pressure. And of course, transcatheter closure is class 1 whenever it is feasible or suitable. And also in patients with significant LV disease or increase in the LV end diastolic pressure, we should first perform a balloon occlusion test before closure of ASD, as those patients have increased filling pressures and may develop left ventricular failure after ASD closure. So you should put in your concentration that if it after doing the balloon occlusion test, you may find the LV end diastolic pressure is still elevated, so you wouldn't close the defector, or you may be able to close it, or another solution, you can close it with a fenestrated device. Another point is that if the pulmonary vascular resistance is from 3 to 5 Woods unit, then ASD closure should be considered, as it is class 2A, but provided that the QP over QS or the shunt fraction is still more than 1.5. And in patients with pulmonary vascular resistance more than 5 Woods unit, you can and you should give them a targeted pulmonary arterial hypertension treatment. And if the pulmonary vascular resistance decrease to less than 5 and still you have a significant shunt fraction which is 1.5, you may be able to close this defect. So again, the main change in the guidelines is that they lower as long as the pulmonary vascular resistance is below 3, or if it is between 3 to 5 and still the shunt fraction is more than 1.5, then you are justified to close the defect. However, if the pulmonary vascular resistance is more than 5, you can give first a pulmonary arterial hypertension treatment and then reassess again. If it is lowered, you may be able to close it. However, if it is not lowered, it is contraindicated to close the ASD. And actually, the same guidelines also goes with intervention in ventricular septal defect. If you have a hemodynamically significant defect and the pulmonary vascular resistance is still less than 3, then it is a class 1 indication. If the pulmonary vascular resistance is from 3 to 5 and you still have a significant shunt fraction, it is class 2A to close the VSD. However, if the pulmonary vascular resistance is more than 5 and the shunt fraction is still significant or more than 1.5, it is class 2B. Those patients, of course, who with Eisenmenger physiology or pulmonary vascular resistance more than 5 Woods unit without significant shunt fraction, it is contraindicated to close the VSD.
Amira,
And also,
Amira, may I ask, so as you said,
yes,
so the main change between the current guidelines and the old one that we had 10 years ago, that
yes,
now BVR more than 5 considered as absolute contraindication. I mean, the old guidelines was 8.
yes, yes,
correct?
Dr. Sa. Yes,
Yeah.
doctor. Yes.
So significant reducing in what we considered operable BVR. So we now are talking between 3 to 5
3 to
instead
5.
of up to 8 in the previous guidelines.
Yes, and yes, totally, Dr. Soha, and they stressed on that you should even calculate the shunt fraction. If it is more than 1.5, then you are justified to close it. I mean, they put the condition of having a shunt fraction of more than 1.5 besides the pulmonary vascular resistance. Yes.
Clear.
Okay.
Thank you.
Thank you, Dr. Sah. Then moving to discussing patients with AV septal defects, either complete AV septal defect, or in other words, complete AV canal, or patient with partial AV septal defect or partial AV canal. Actually, complete AV septal defect are those patients who are having mostly the same physiology as those with VSD. So the same guidelines for VSD intervention or closure goes for patient with complete AV canal, and actually patient with partial AV canal, they have the same pathophysiology and hemodynamics of patients with a large ASD. So the same guidelines for ASD intervention or closure goes for those patients with partial AV septal defect, but of course it is only surgical intervention. And however, the guidelines added a new point for intervention in those patients who have a significant or a severe AV valve regurgitation in patients with common AV canal after surgery. If those patients are symptomatic, then preferably systemic AV valve, then preferably the AV valve repair is class 1. And if those patients are asymptomatic, then you should follow the left ventricular insystolic diameter. If it increased to more than 45 millimeter, or the ejection fraction started to decrease to be less than 60, then it is also class 1 to repair the AV valve. Then we will move now to the shunt lesions, the LVOT tract obstructions and the RVOT tract obstruction. First, I will start with the LVOT tract obstruction, starting with aortic stenosis. And actually, I think that the guidelines in other congenital heart disease, it goes very likely as the guidelines for aortic stenosis, as we all know that patient with symptomatic severe aortic valve stenosis with mean pressure gradient more than 40 millimeter mercury, it is class 1 indication for intervention. And also patient with severe low flow low gradient aortic stenosis, in which the ejection fraction is in which the mean gradient is less than 40 with depressed ejection fraction. However, they have a proven contractile reserve, it is class 1 for intervention. And those patients with asymptomatic severe aortic stenosis, and there is a decrease in exercise capacity on testing, or a decrease in the left ventricular functions to be less than 50, or a significant fall in the arterial blood pressure during exercise testing, then those are all indications for intervention in those patients. Regarding the supravalvular aortic stenosis, also the guidelines had lowered the threshold for intervention in those patients, where in patients with symptomatic supravalvular aortic stenosis and the mean pressure gradient is more than 40. In the previous guidelines, it was 50 millimeter mercury. They lowered it to 40, so they are class 1 indication for surgical intervention. And even those patients who have a mean pressure gradient less than 40, but they are symptomatic or they have a significant LV dysfunction, it is also class 1 for surgical intervention. And also the same guidelines goes for subvalvular aortic stenosis or subaortic membrane, that if you have a symptomatic patient with mean pressure gradient more than 40 or even severe aortic regurgitation, it is class 1. Even if the mean pressure gradient is less than 40 and with depressed ejection fraction less than 50, it is class 2A for surgical intervention. And they added that if you have a severe aortic regurgitation, it is also indication for surgical intervention. Regarding the aortic coarctation, actually the guidelines didn't change dramatically. They just the same threshold for intervention, which is a peak-to-peak pressure gradient, either in non-invasively or invasively more than 20 millimeter mercury. It is class 1. However, they put the catheter treatment or stenting as a class 2A whenever feasible for those patients. Even if the pressure gradient is less than 20 and they have more than 50% aortic narrowing, it is class 2A for aortic coarctation stenting. Then we will move to the second category, which are those patients with RVOT obstruction at any level, either subvalvular, valvular, or supravalvular. So as we all know that patients with severe valvular pulmonary stenosis, the balloon valvuloplasty is class 1 indication for all those patients. And actually the threshold for intervention in patient with the valvular pulmonary stenosis is when the pressure gradient is more than 64 millimeter mercury. And surgical valve replacement is also still class 1 in those patients who are not fit for balloon valvuloplasty. For example, if you have a severe subvalvular RVOT obstruction or supravalvular RVOT obstruction or dysplastic pulmonary valve with multiple redo balloon pulmonary valvuloplasty, and still they have a significant pressure gradient, so surgical valve replacement is can be an option for those patients. Even if you have it will be an option if for those patients if they are asymptomatic, however they have an objective decrease in exercise capacity, or they have a right ventricular impaired right ventricular function or right ventricular systolic pressure more than 80 millimeter mercury. And regarding the indications for intervention in patients with peripheral pulmonary stenosis, it is class 2A for catheter intervention, for example, balloon dilatation or even peripheral pulmonary artery stenting, if there is more than 50% narrowing in the diameter of the pulmonary artery, or the right ventricular systolic pressure is more than 50 millimeter mercury, or in other words, if you have right ventricular systolic pressure more than 2/3 of the systemic pressure. Then the third category here will be those patients with congenital cyanotic heart disease. And actually, as I said previously, that we commonly face those patients after surgical repair. So we should put in mind the complications after surgery and how to manage it. Patients with tetralogy of Fallot after repair, the most common complication that we all know that those patients, due to the previous technique where they use a pericardial patch, so they commonly develop pulmonary regurgitation, or if they had an RV to pulmonary artery conduit, they commonly develop RV to pulmonary artery conduit stenosis or obstruction. They may have a right ventricular dysfunction or severe tricuspid regurgitation or residual VSD or an aortic regurgitation with the dilated aortic root, and less commonly to develop left ventricular dysfunction. However, we may see this complication in patients who were repaired later in life, or they had a delayed repair in life, or patients who may have a coronary injury during surgery may develop left ventricular dysfunction. And commonly, those patients are subjected to all types of arrhythmias, with either atrial or ventricular arrhythmias, or peripheral pulmonary artery stenosis. So regarding the recommendation for intervention for patient after a repair of fallot, the first complication I mentioned is and we commonly face, is the severe pulmonary regurgitation. So patients with symptomatic severe pulmonary regurgitation, that is class 1 for intervention. And also, if the patient is having a moderate to severe RV tube obstruction, in case of RV to pulmonary artery conduit, is also class 1 indication for intervention. And what is new in the guidelines is that they put the catheter intervention, I mean the transcutaneous pulmonary valve implantation, as a class 1 whenever anatomically feasible, and whenever the anatomy is suitable for valve implantation. So it is class 1. And also, the guidelines stated another guidelines for determining for those patients who need pulmonary valve either replacement or implantation. If you have an asymptomatic patient with severe PR, however, the right ventricular end diastolic volume indexed is more than 160 milli per meter square, or an end systolic volume is more than 80, then they are class 2A for pulmonary valve intervention, or even the RVSP is more than 80 millimeter mercury, or any form of right ventricular dysfunction or objective decrease in exercise capacity. This regarding management of the pulmonary regurgitation. Regarding the management of residual VSD, which is not uncommonly seen in those patients, if the VSD is large and hemodynamically significant, it is indication either for transcatheter closure or surgical closure if the transcatheter is not feasible. And again, ICD implantation is indicated in patient with a tetralogy of Fallot if they developed, as we said earlier, as a hemodynamically significant VT, or even in patient in fellow patient who have a left ventricular dysfunction, non-sustained VT, or QRS duration more than 180, or extensive right ventricular scarring on cardiac MRI, then they are class 2A for ICD implantation. Then we will move to the second. Yes, Dr. So.
If I may make a comment on the previous slide.
Yes.
So now in the current guidelines, as you said, for first time that we see class 1 the intervention. So it is after the successful 10 years, the past 10 years. So actually, the implantation and the other devices should really a release from a stress of recurrent operation doses in those patients. So I think this is really justified to have this recommendation if the anatomy feasible, as they said. And for the criteria of severe pulmonary incompetence, so I think it is the same like previous guideline, that end systolic is more than 80. But here, the end diastolic volume increased to 10 milliliters. So actually, in the previous guideline, 150. But currently, the guidelines give us some more volumes. So it's 160. And mention here progressive RV systolic dysfunction. Actually, they didn't mention a figure, but the figure is around 47 ejection fraction or something like that. So I think the number of end diastolic volume had been changed, increased the 10 milliliter.
Yes, Dr. Soha, but I think they should have added that these parameters should be mentioned only by cardiac MRI because it is the gold standard.
Yeah, I think they mentioned it by cardiac. They meant the MRI, I think.
Yes, thank you, Dr. Soha.
You're welcome.
Then I will move to another category, which is patients with transposition of great arteries, or TGA, and we mean here patients with DTGA. And actually, those patients either have two types of operation: those patients who underwent atrial switch operation or arterial switch operation. Patient who underwent atrial switch operation, they are subject for development of the following complication. They may have baffle stenosis or leakage, systemic baffle stenosis or leakage, or pulmonary venous baffle also stenosis, or they may have a systemic right ventricular dysfunction or systemic AV valve dysfunction, or induced left ventricular outflow tract obstruction, or of course all types of tachycardias, either supraventricular tachycardias or ventricular tachycardias. While patients with or after arterial switch, as those patients have neo aorta, so they may develop an aortic root or neo aortic root dilatation, or aortic valve regurgitation, or any coronary abnormalities, or later on they may develop peripheral main pulmonary artery or peripheral pulmonary artery stenosis. So we should put in mind all these complications, and as we all know, the most common is baffle stenosis or leakage when we follow up those patients. And actually the guidelines mentioned those complications and the optimum management for them. If you have a symptomatic patient after atrial switch and they were having a significant baffle stenosis or baffle leakage, the catheter intervention for stenting of the stenosis or closure of the baffle leakage by a device is class 1, and if it is not an option, also surgical intervention is class 1. So regarding significant baffle stenosis or leakage in symptomatic patient, both catheter intervention if feasible, and if not feasible, surgical intervention is recommended in those patients. And if those patients develop severe tricuspid AV valve regurgitation or systemic AV valve regurgitation, and still the ejection fraction is more than 40%, then it is class 2A for valve repair or surgical replacement of the valve. Then we will move to patient with congenitally corrected TGA. Yes,
I have a comment that might be a funny comment, but actually I'm surprised to see in the guidelines of 2020 atrial switch. So I think the last time that the Wisterian wallet did an atrial switch, it was 40 years ago. I mean,
for us,
yeah, I mean, no, I mean in the European. I mean, this is European guidelines. So actually, yes, when I was in my training in Holland, so actually they said that 20 years ago they didn't do any atrial switch because arterial switch is the guy. So I'm really surprised a bit to find this guideline. So actually I think that all the patients that they have an atrial switch is 50 plus or something like that in Europe, but still they put it in the guidelines. So just a comment that they don't do an atrial switch for the last 40 years.
Yes, yes, Dr. It's funny, but I think they may. Dr. Haitham, go on.
That they are mentioning the atrial switch to highlight the complications or the amount of complications the patient are facing, not recommending it for treatment of TGA, but to highlight that these patients have a lot of complication and the management of these complications. As you said, that these patients are now 50 plus, they are liable for more complications that they can handle, and that's why they are still mentioning the complication of this procedure. But I don't think they will recommend this procedure anymore. Yeah.
Not anymore.
Yes, but a funny thing too, Dr. Haitham and Dr. Suha, I do think they tailored it for us, or for patient for countries who still do atrial switch, because in Egypt, and I face it a lot, we saw patients with TGA with late presentation, and actually they have passed the period where they were eligible for arterial switch, where we find there is a significant LV dysfunction, or the left ventricle becomes smaller or compressed, so they are no more candidates for such operation. Yes, so we still have, I still see patients who do atrial switch in here in Egypt. Yes. Then moving to patients with congenitally corrected TGA, the commonest complications where we face in those patients, of course, we know that those patients, sometimes patients with congenitally corrected TGA, or not sometimes, most of patients, if they don't have significant intercardiac mixing or they don't have a significant shunt, we keep those patients without surgery for adult life, because they are not desaturated, and so they they go well regarding the symptoms and the functional capacity, but the main problem is that they develop a right ventricular dysfunction because the right ventricle is the systemic ventricle. So this is the main complication in those patients. Or also they develop a significant tricuspid regurgitation, as the tricuspid valve is the systemic AV valve. Less commonly they have an LVOT obstruction, and not uncommonly actually I saw a lot of patients with congenitally corrected TGA who had a significant complete heart block or a Mopitz type 2 heart block. So these are the common complication we see in those patients. So regarding the guidelines, it mentioned that patient with severe tricuspid valve regurgitation or systemic AV valve regurgitation, and still they have a preserved ejection fraction which is more than 40%, they are candidates for tricuspid valve replacement, even if they were asymptomatic. And patients who develop significant complete heart block or develop a considerable complete heart block, they are candidates for biventricular pacing. I mean, those patients in adult life who develop a Mopitz type 2 heart block or complete heart block, biventricular pacing, for example, DDD implantation is class 2A in those patients. Then moving to another category regarding patients who have an RV to pulmonary artery conduit. Sometimes patients with pulmonary atresia and ventricular septal defect, they do an RV to pulmonary artery conduit, or in fellow patients with a severe dysplastic pulmonary valve, they have an RV to pulmonary artery conduit. So the indication for re-intervention in those patients, either surgical valve replacement or catheter intervention, if they were symptomatic and the right ventricular systolic pressure is more than 60 millimeter mercury, or they developed a severe pulmonary regurgitation. Catheter intervention is class 1 in those patients. So patient with RV to pulmonary artery conduit and RVSP is more than 60, or they have a severe PR, catheter intervention is class 1. Even if those patients were asymptomatic and they have an objective decrease in exercise capacity, or again an increase in the RV in systolic volume more than 80, or in diastolic volume more than 160, or RVSP more than 80, or progressive right ventricular dysfunction, this class 2A for transcatheter pulmonary valve implantation. Then we will move to another category, which are patients with univentricular heart, or in other words, functionally single ventricle. And I think we discussed it in details in the previous sessions, but I will go rapidly through them. If we just want to remember patients who fall under the category of functionally single ventricle, those patients with tricuspid atresia, double inlet left ventricle, or hypoplastic left heart syndrome, or patient with pulmonary atresia, intact interventricular septum, or those patients with unbalanced common AV canal. And actually, they have two hemodynamically significant types, either those with increased pulmonary blood flow or those with decreased pulmonary blood flow. Commonly, we don't face those patients unrepaired in adult life. However, if the guidelines recommend of those adults were unoperated, they should be carefully again evaluated in a specified congenital heart disease center. And only patients with low pulmonary vascular resistance and they still have a preserved ventricular functions, they are candidate for Fontan operation after Glenn. And if those patients were unrepaired and they have an increased pulmonary blood flow, then they are candidate for pulmonary artery bending. Or if those patients were unrepaired and presented with severe cyanosis and marked decrease in the pulmonary blood flow, they should be considered for a bidirectional Glenn shunt. However, those patients with the worst prognosis, they may be later on candidates for heart transplantation or heart-lung transplantation. And as those patients with functionally single ventricle or univentricular heart or univentricular repair, they are a special population, then they should be advised, as we said previously, regarding pregnancy and contraception. For example, if the saturation is less than 85 or 90, they should be advised against the pregnancy, and they should be advised against the optimum method for contraception. As we said previously, COC is not recommended, and sometimes the IUD device is also not recommended. So POP is a most recommended method of contraception. And regarding exercise and sports, they may be allowed to do symptom limited recreational sports, and prophylaxis against infective endocarditis is of extreme importance in those patients. Regarding patient with or after Fontan or after complete cavopulmonary anastomosis, first of all, we should select those patients with strict criteria, as they are a patient after Fontan operation are very fragile group of patients. And actually the idea for Fontan, as we discussed previously, is separation of two ventricles without having a subpulmonic ventricle to restore the two circulation back in series. And the aim of the Fontan operation is to improve saturation. So actually these patients may have a saturation up to 95 or even 99%. However, their altered hemodynamics makes them face a chronic systemic venous hypertension or a chronic preload deprived ventricle and significant pulmonary hypertension due to altered pulmonary hemodynamics. So again, I will revise rapidly the early and late complications for patients after Fontan. They may have systemic ventricular failure or severe systemic AV valve regurgitation, pulmonary hypertension, or rise in pulmonary vascular resistance, thrombotic complications as right atrial and pulmonary artery thrombus formation, all types of arrhythmias, complication of chronic venous hypertension starting from hepatic congestion, hepatic fibrosis, or chronic liver cirrhosis up to hepatocellular carcinoma, and protein losing enteropathy and the associated pleural effusions and ascites. So regarding those group of patients, the guidelines again give recommendation regarding the management of those complications. So if a patient is having sustained atrial arrhythmia with rapid AV conduction, they should undergo rapid electrical cardioversion. This is class 1. And again, anticoagulation is of utmost importance in patients with Fontan after Fontan circulation. And women with Fontan circulation, they should be advised against pregnancy, and cardiac catheterization is recommended if you notice any unexplained cyanosis or deterioration in functional capacity in those patients. And again, as we said before, regular liver imaging as ultrasound and alpha fetoprotein is important in those patients, as we discovered lately that they may develop hepatocellular carcinoma. And for management of pulmonary hypertension, endothelin receptor antagonist and phosphodiesterase enzyme inhibitor may be considered in those patients with pulmonary hypertension. So I now finished the main recommendations regarding the guidelines of adult congenital heart disease, and I will just revise the guidelines where there was a dramatic change. As I said and discussed with Dr. Soham, that in patients with shunt lesions, either ASD, VSD, or PDA, they lowered the threshold for pulmonary vascular resistance to be less than 3 as a class 1 for indication in those patients. And if the pulmonary vascular resistance is from 3 to 5 and you still have a significant shunt fractions, then it is class 2A. However, if the pulmonary vascular resistance is more than 5 Woods unit and you give a targeted pulmonary arterial hypertension treatment, I mean a medical treatment, and it was lowered, so it is class 2B for ASD closure, and fenestrated device, you are only justified to close it with a fenestrated device. And if the pulmonary vascular resistance is more than 5 Woods unit in a patient with VSD or PDA, you should carefully take the decision whether to close the device or whether to close the device. close it or not. And also it is class 3 left ventricular disease or LV dysfunction or increase in LV in diastolic pressure. It is recommended that you should do first a balloon occlusion testing to evaluate whether this patient is having an increase in the left ventricular filling pressure or not. So you may be able to close it, or you may take a decision not to close it, or you may take a decision to close it with a fenestrated device. Another dramatic change in the guidelines, as I discussed earlier, is that they lowered the threshold for intervention in all patients with significant LVOT obstruction from 50 to 40 millimeter mercury, whether it was supravalvular aortic stenosis or subvalvular aortic stenosis or subaortic membrane. And another dramatic change, that they put the catheter intervention or coarctation stenting as a class 2A for patients with a hemodynamically significant coarctation with invasive pressure gradient more than 20 millimeter mercury, or even if there is only more than 50% narrowing of the descending aorta. And also, one of the changes regarding intervention for patient with after tetralogy of fallow repair or RV to pulmonary artery conduit, whether they have a significant pulmonary valve regurgitation or a significant RVOT obstruction, the transcatheter pulmonary valve intervention became a class 1 for those patients. And as we said, they increased a little bit the threshold for the RV in diastolic volume index, and instead from 150 to be 160 millimeter per meter square. So these were the main changes that I want to highlight regarding the latest adult congenital heart disease guidelines. And also a dramatic change in the title of the guidelines, that they changed it from grown-up congenital heart disease guidelines or GUCH guidelines to adult congenital heart disease guidelines. Thank you.
Thank you, Amira. This was really a comprehensive analysis for that. And I agree that it is not anymore a grown-up congenital heart disease. I mean, we have old patients. They are 60 plus, so I think they had a point to change it to adult congenital heart disease.
Yes,
thank
Dr.
you, Amira. I really enjoy it. Thank you.
Dr. So, thank you, Dr. So. Thank you, Dr. Haitham.
Thank you, Amira. It was a lovely and elegant presentation. And it's obvious the effort you did to group this complex guidelines into these slides. I have, I wonder if they have a strict instructions about the follow-up of these patients. We see that there is a lot of information about change in pressures, change in volumes of these patients that indicates after procedure intervention or after procedure management. So this means that we should follow up our patients efficiently with
Yes.
An accurate mode of investigation in order to pick up these patients before they reach a critical stage. So in your opinion, is there is any strict indication or strict follow-up schedule of these patients in the guidelines?
Yes, Dr. Haitham, I wondered if they mentioned any time plan for management of those patients, but there were no strict recommendations regarding the time plan. But as I said in the first, it is a lifetime journey, or it is a long life disease. So I think if we could follow up them, or patient with high risk categories should be followed at least annually by ECG, chest X-ray, and echo. I think it would be suitable. I don't know whether do you agree with me or not.
Okay, so let's brainstorm ourselves.
Yeah.
Yes, the conventional methods the ECG, the X-ray, and the echocardiography
Yes.
annually will be suitable. And I vote to add a station of 5 years to perform cardiac MRI for these patients, if it's feasible. I think the wealth of information given by the cardiac MRI will help us more to detect any changes in particularly in the volumes and in the pressure gradients of these patients
Yes.
before they develop an end-stage disease. So what do you
Yes.
think, Dr. Soha and Dr. Amira?
Yes, I do agree that in the current era, cardiac MRI, especially cardiac MRI, and to great extent CT, but with restriction due to the radiation hazards, add really a lot of information that we were not able to get because of the limited acoustic echocardiographic views in our patients. So I think yes, MRI could help in quantification and also in anatomy.
Yes, I do totally agree with both of you, Dr. Soha and Dr. Haytham. But what do you think if in special groups as the patients with after tetralogy of fellow repair, if they are at high risk or symptomatic, should we make the cardiac MRI follow-up, for example, every 2 years for close-up assessment? I don't know.
I think annually, if the patient,
Yes.
if the, I think annually, yeah. MRI should be done annually
Yes.
if there is a severe incompetence.
Yes, yes, Dr. Soha, I do agree.
Yes, this is a very, very important and crucial point. To
Yes.
tailor your schedule of follow-up according
Yes.
to every patient status. If
Yes.
you consider your patient is a high-risk patient, you will
Yes.
begin to have the conventional methods every 6 months, and to have an advanced method like the cardiac MRI every 1 year, and
Yes.
tailor your methods and schedule of follow-up according to the evolvement of every patient.
Yes.
So yes, I do agree about increasing the follow-up visits and ameliorating the follow-up methods according to the complexity of every patient.
Yes. Yes. Yes, Dr. Haytham. Thank you.
You're welcome.
Thanks a lot, Dr. Amira, for this great discussion. And thanks a lot, Dr. Soha and Dr. Haytham, for moderating this elegant webinar. I know it was a hard job to collect all the guidelines in one single webinar, because actually the amount of data is really big, and Amira did a very big job and a great job actually to finish this webinar in time. So I would like to thank you again so much, Amira, for your great effort, and thank you, Soha and Haytham, for this great moderation. So actually now the congenital heart disease course at CEC has been completed, and this could not have been done without the effort of every single person in the congenital heart disease at CEC group, and all of our speakers and moderators, starting from the first webinar up to webinar number 16, which we are currently running now. This could not have also been completed without the great effort from the board of the CEC, Dr. Haytham Suleiman, Dr. Karim Mahmoud, Dr. Ahmed Saeed, and Dr. Abdurrahman Gamal. I would like to thank them all. We would not have been completing this without the passion and the hope and lightening of the track by all of our viewers and audience that continuously give us the feedback and continuously give us the motive for seeking better and better regarding every step that we do. I think we will take a break for a few weeks before we start our echocardiography course. We are planning and structuring currently now with international bodies a big echocardiography course involving the basics and the advanced echo, and this will be streamed also on the Saturdays. So actually, the next few Saturdays, maybe 4 or 5 weeks, will be off, and then we would restart again, maybe by the middle or the end of by the end of October or the middle of November. I would like to thank you all for attending with us, and I would like to thank again all the congenital heart disease team from Ain Shams University and from Aswan Heart Center. I don't want to mention names because every one of them is a participant in this team. And also thanks a lot to all the CEC board and to all our viewers, and hopefully we will meet you very soon in the congenital heart disease course, in the echocardiography course. So good night.